Welcome to the deep dive. Today we are taking a massive swing at the essential, often unseen, science that governs one of modern medicine's most critical and, well, high-stakes acts, prescribing drugs.
It's such a foundational area and one that really every patient should understand on some level.
Yeah.
Prescribing is, you could argue, the most powerful tool a clinician has to restore or preserve health.
But it's a tightrope walk.
It absolutely is, inherently a tightrope walk.
And the mission here is to get that prescribing is so much more than just matching a symptom to a drug. It's a careful, calculated balance. You're constantly weighing the benefits against the cost, and most crucially, against the potential for adverse drug reactions, ADRs, and dangerous interactions.
And that tightrope is getting, well, significantly thinner. The modern challenge is the explosion of polypharmacy.
Meeting patients on multiple drugs at once.
Multiple complex regimens simultaneously. It's a huge challenge in the aging population.
Yeah.
And the sheer number of available drugs, different formulations, genetic variables, it all means the prescriber has to be a genuine expert in risk calculation.
So, before we can even talk about the principles of good prescribing, we need that scientific foundation. The roadmap for this deep dive needs us to understand two core concepts. First, pharmacodynamics.
What the drug does to the body.
Right. And second, pharmacokinetics.
What the body does to the drug.
Exactly.
And if you, the listener, want to be truly well-informed about modern medicine, you really need both sides of that equation. We need the science to predict if it will work, and we need the practical risk management to, anticipate and avoid harm.
Okay, so let's unpack this. Starting with pharmacodynamics, we're diving right into the molecular mechanics, right? Where the effect actually begins.
It's a marvelous world of miniature machinery. Modern drugs work by targeting very specific molecular sites, either stimulating their function or blocking them.
And it's not just one simple lock and key thing.
Oh, no. The source material categorizes these into a wonderfully diverse, highly specialized group.
A whole suite of cellular controls.
That's right. The most common targets are receptors, and even within that, we have four major subtypes. First, there are the channel-linked receptors.
Okay.
Here, the drug binding directly controls the opening or closing of an ion channel. Think of the nicotinic acetylcholine receptor. The drug is a literal molecular gatekeeper.
So the action is immediate. That's right there.
Immediate and localized. Then you have the largest and maybe most complex family, the G-protein coupled receptors, or GPCRs.
Right.
With these, the drug binding doesn't just open a channel. Instead, it triggers a secondary cascade. It affects the G protein, which then, sends signals out, often activating enzymes or controlling other channels elsewhere in the cell.
So the GPCR is less like a gate and more like a huge cellular switchboard.
That's a great analogy. It gets a signal and then initiates a chain reaction inside the cell, a cascade effect. Key examples are the beta-adrenoceptors that control heart rate.
Okay, and the third type?
The third type is kinase-linked receptors. These are often focused on things like growth and repair. Binding activates a protein kinase inside the cell, which starts a cascade of phosphorylation reactions that change cell function over a much longer time frame. The insulin receptor is the classic example here.
And the final type, the ones that have to go deepest into the cell.
Those are the transcription factor receptors, or nuclear receptors. They're intracellular, located inside the cell nucleus. When the drug binds, it actually promotes or inhibits gene transcription.
So it's telling the cell to make new proteins.
Exactly. It's telling the cell to build new machinery. And because of that, the effects, like from steroids or thyroid hormones, are often delayed by hours or even days.
Now, beyond receptors, the source reminds us drugs can target other essential things as well.
No, they do. We target voltage-gated ion channels, the ones behind electrical signaling in nerves. We target enzymes like ACE or cyclooxygenase, basically getting in the way of their natural job. We block transporter proteins.
Like with antidepressants.
Like the 5-HT reuptake transporter, yes. And with modern biologics, we're increasingly targeting cytokines and even cell surface antigens.
This detail really highlights the complexity. For a drug to work, it has to interact perfectly with its target. And how well it does, that comes down to two things: affinity and selectivity.
Right. Affinity is the measure of molecular attraction, the propensity for a drug to bind to its target. It depends on the precision of the molecular fit and the strength of the bond. And we should note some interactions can be irreversible.
And selectivity is often misunderstood. We hear highly specific drug, but the source says selectivity is always relative.
That is a critical nuance, and it's where clinical risk often lies. Selectivity describes a drug's preference for one target over another, But even a highly targeted drug will have some effect on related targets, especially if the dose gets high enough.
The beta-adrenoceptor example is perfect here.
It's the paramount example. So the body has different types of beta-adrenoceptors. Beta-1 receptors are mostly in the heart, controlling heart rate.
Tachycardia.
Yes. And beta-2 receptors are in the lungs, and they cause bronchodilation, opening up the airways. So if a patient has, say, heart failure, we want a beta blocker to decrease heart strain. We want to block beta-1.
So you'd choose a cardioselective beta blocker to try and avoid the lung.
Exactly. But because selectivity is only relative, if that patient also has asthma, even that beta-1 selective drug can still bind to the beta-2 receptors in the lungs at normal doses.
And trigger a dangerous bronchospasm.
A dangerous bronchospasm. This makes beta blockers a crucial contraindication for asthmatics. A good prescriber has to know that even a selective drug is not truly specific. That relative difference is the difference between success and an emergency room visit.
That distinction is incredibly helpful. Now, once a drug binds, it can play one of two roles, agonist or antagonist.
Right. Agonists bind and produce a conformational change that generates a response. They activate the receptor. But there's a spectrum. A full agonist produces the maximal signaling effect possible.
The highest volume.
Right. A partial agonist also binds and activates. But even if it occupies all the available receptors, it just can't achieve that maximal response.
So it binds, it switches it on, but the volume knob only goes so far.
Precisely. Antagonists, on the other hand, they bind, but they do not produce that change. They just block the binding site and prevent the natural agonist from acting.
And there's competitive versus non-competitive?
With competitive antagonism, the drug competes directly with the natural ligand for the binding site. The outcome depends purely on the relative concentrations. If the body dumps enough natural ligand, say a massive surge of adrenaline, you can often overwhelm the competitive antagonist.
So you can bypass the blockage in a crisis.
Yes. But with a non-competitive antagonist, the drug inhibits the effect through other mechanisms. Maybe it binds irreversibly or affects signaling further down the line. You cannot overcome their effects just by increasing the concentration of the natural agonist.
Which makes it more robust, but probably harder to reverse if something goes wrong.
Exactly. Harder to reverse in cases of toxicity.
Okay, that really sets the scene on the microscopic level. Now let's move from molecular binding to what we can actually see in the patient, dose and response.
Right, this is where we get the sigmoidal dose response curve. It plots the log of the dose against the effect, and it gives us our key metrics for comparing drugs.
The first one being efficacy.
Efficacy, or Emax, defines the maximal response a drug can produce. It's the ceiling. It's how we compare drugs that might even act on different targets. For example, loop diuretics have greater therapeutic efficacy than thiazide diuretics because they just induce a greater, higher maximal diuresis.
So efficacy is about how good the drug can be. Potency is about how much of it you need.
Correct. Potency, or ED50, is the amount of drug needed to get 50% of the maximum response. A more potent drug just means you need a lower dose. And crucially, a low potency doesn't mean a drug is bad. You can just overcome it by giving a higher dose, as long as the efficacy is the same.
Now, the relationship between the good dose and the toxic dose brings us to the therapeutic index, or TI. This is basically the definition of safety.
It is the safety margin. The TI is the ratio of the ED50 for the major adverse effect to the ED50 for the therapeutic effect. For most modern drugs, the TI is huge, over 100, which gives prescribers a lot of room to move.
But the danger is in that handful of essential drugs where the margin is razor thin.
And this is a crucial insight for anyone who wants to be well informed. You have to know the drugs with a TI of less than 10. These include digoxin, warfarin, insulin, phenytoin, and opioids.
Wow, that list covers heart failure, anticoagulation, diabetes, seizures, pain. These are cornerstones of modern medicine.
They are. And that low TI is why they demand such careful individualized titration. Take warfarin. You have to constantly monitor it, not just because it interacts with everything, but because the therapeutic window, the space between effective and dangerous, is so incredibly small.
So a slight change in diet or compliance can push a patient into the toxic zone.
Instantly. These drugs demand constant monitoring to maximize benefit while avoiding acute toxicity.
Okay, finally in this section, we have to talk about what happens when a drug is used continuously. The body starts to adapt. Desensitization.
Right, a diminished response over time. And we differentiate between two types based on speed. Tachyphylaxis is very rapid desensitization, sometimes after just one dose.
So you run out of fuel almost immediately.
That's a good way to think of it. It implies you've depleted something, like stored neurotransmitters. Tolerance is a more gradual loss of response over days or weeks. This is usually due to slower physiological changes, like the body physically reducing the number of receptors on the cell surface.
And if the body adapts to offset the drug, stopping it abruptly can cause a rebound effect.
A withdrawal effect, and these can be severe. With glucocorticoids, chronic use suppresses the body's natural stress response axis. If you stop the drug suddenly, the patient can go into acute adrenal insufficiency, which is a medical emergency.
And even common drugs like SSRIs need to be tapered slowly.
Absolutely. Stopping them too quickly can cause a discontinuation syndrome, dizziness, nausea, insomnia. A good prescriber knows that the adaptation process means you have to introduce the drug slowly and withdraw it slowly to keep the patient safe and stable.
Okay, so with pharmacodynamics covered, let's move to pharmacokinetics.
What the body does to the drug, this is what determines where the drug goes, how long it stays, and how it leaves. It explains the majority of why patient A responds differently than patient B.
We're tracing the drug's path: absorption, distribution, metabolism, and excretion. ADME. Let's start with absorption.
The oral route is by far the most common, but absorption is complex. We have to define bioavailability, which is the proportion of the dose that actually reaches the systemic circulation intact.
And oral absorption is unreliable because the drug has to run a gauntlet.
It does. It has to survive stomach acid, avoid binding to food, cross the intestinal wall, and then crucially survive extensive first-pass metabolism in the liver.
So the liver treats everything from the gut as a potential toxin and starts clearing it before it even reaches the rest of the body.
Exactly. For some drugs, like propranolol or morphine, this first-pass effect is so significant that only a tiny fraction of the oral dose, sometimes less than 20%, makes it into the bloodstream.
Which means the oral dose has to be much higher than an IV dose.
Dramatically higher, and the final amount is highly variable from person to person.
So how do we bypass that first pass trap?
By using other routes. Buccal, or sublingual under the tongue, like nitrates for angina, allows for rapid absorption directly into the systemic veins, skipping the liver entirely.
And rectal administration.
That partially avoids the first pass effect and is useful if a patient is vomiting.
Then you have the parenteral routes, which eliminate that variability.
Intravenous or Movius are the gold standard. 100% bioavailable, rapid, certain. It's indispensable for critically ill patients, like giving IV benzyl penicillin for suspected meningitis. Every minute matters.
And injections into muscle or fat.
Intramuscular, or IM, is easier than IV, but absorption depends on local blood flow. Subcutaneous, or SC, into fat, is great for self-administration of drugs that can't survive the gut, like insulin or heparin.
Okay, once in the blood, the drug is distributed. Where does it go?
It moves between the circulation, the fluid around cells, and into the cells themselves. And this is heavily influenced by lipid solubility, molecular size, and binding to plasma proteins, especially albumin.
This brings us to that conceptual metric, the volume of distribution, or VED.
VED is an apparent volume. Think of it less as a literal volume of water and more as a metric for how sticky the drug is, how much it likes to hide outside the bloodstream.
And the size of the VED tells us exactly where the drug is higher.
Precisely. Drugs that are highly bound to plasma proteins stay in the blood, so they have a low VED, less than 10 liters. Warfarin is a good example.
Okay.
Conversely, highly lipid-soluble drugs, like many antidepressants, are highly tissue-bound. They accumulate in fat or muscle, giving them a huge VED, sometimes over 100 liters.
And the clinical implication is that if a drug is hiding deep in the tissues, it's hard to get rid of it.
Correct. You can't easily dialyze it out in an overdose because so little is actually circulating in the blood, and they also have much longer half-lives.
Next up is metabolism, where the drug is chemically changed for removal.
The liver's main goal here is detoxification. It has to convert these lipid-soluble drugs, which were easy to absorb, into a water-soluble form that the kidneys can flush out.
This is also where we see prodrugs.
Yes, inactive compounds that rely entirely on the liver to convert them into their active form.
And we break metabolism into two phases.
Phase I involves oxidation, reduction, or hydrolysis. Oxidation is the main process, driven by the incredibly versatile cytochrome P450, or CYP, family of enzymes in the liver. These enzymes are the most common site of drug interactions. They are critical players.
And phase II makes the drug water-soluble for good.
Phase II is conjugation. The phase on metabolite is linked with something endogenous, usually glucuronide. This creates a highly water-soluble inactive conjugate that can be easily excreted by the kidneys.
Finally, excretion. Getting it all out.
Renal excretion is the primary route for water-soluble drugs, but we can actually manipulate this process. For weak acids like aspirin, if we alkalize the urine, we can trap the drug in its ionized water-soluble form and accelerate its excretion.
A key strategy in an
A
overdose.
very common strategy. And then there's fecal excretion for large drugs and the fascinating enterohepatic
The
circulation,
recycling loop?
the recycling loop.
Mm.
Drugs excreted in the bile can be reabsorbed in the gut and sent back to the liver. This can dramatically extend the duration of action for drugs like morphine or digoxin.
Okay. Knowing how the drug leaves the body lets us talk about elimination kinetics and how that dictates the dosing schedule.
Most drugs follow first-order kinetics. The elimination process is not saturated, meaning the rate of elimination is proportional to the concentration. A constant fraction is eliminated per unit time. It's safe and predictable, and it lets us define the half-life.
But then we hit the highly unpredictable zero-order kinetics.
This is where elimination capacity is saturated within the therapeutic range. The body can only eliminate a constant amount of the drug per unit time, regardless of how high the concentration gets. The classic examples are phenytoin and alcohol.
Why is this so dangerous for the prescriber?
Because the relationship between dose and plasma concentration becomes nonlinear. With the first-order drug, you double the dose, you double the concentration. With a zero-order drug like phenytoin, a small increase in the dose can cause the drug to accumulate progressively and unpredictably, leading rapidly to serious toxicity. You feel like you're flying blind.
The goal of continuous dosing is to reach a therapeutic plateau, the steady state.
Right. Steady state is when the rate of administration equals the rate of elimination. And here's the crucial rule. It typically takes approximately 5 half-lives to reach steady state.
So if a drug has a half-life of 36 hours, like digoxin, you're waiting over a week for the full effect. That's not acceptable if the patient is acutely ill.
And that's exactly why we use a loading dose. For drugs with long half-lives, we give a larger initial dose to bypass that waiting period and rapidly get the concentration up into the therapeutic range.
But if a loading dose immediately puts the patient near the toxic threshold, doesn't that inherently increase the risk, especially for a low TI drug like digoxin?
It absolutely does. A loading dose is inherently a high-risk maneuver. You're putting a large amount of drug into the system at once, rapidly testing the patient's individual tolerance. It requires very careful calculation and monitoring.
Finally, we have the dose interval compromise.
It's a trade-off.
Yeah.
Infrequent dosing is more convenient for the patient, which helps with adherence, but it creates bigger swings between peak and trough concentrations. For drugs with a short half-life or a low TI, those big swings risk both toxicity at the peak and failure at the trough.
Which is why we have modified release formulations.
Exactly, to smooth out that curve and keep the concentration within that narrow therapeutic range all day long.
Okay, here's where it gets really interesting because we're moving from the predictable science to the unpredictable individual. Prescribing is always a trade-off, and the huge challenge is accounting for the massive variation between patients.
It is. Standard clinical guidance is based on average data from trials. But when you apply that to a single patient, individual variability just kicks in due to differences in their specific pharmacokinetics and pharmacodynamics.
What are the biggest non-genetic factors driving that variation?
The source summarizes several key ones. Age is paramount. As we get older, renal function declines, reducing drug elimination. Sex also matters. Women tend to have more body fat, which increases the volume of distribution for lipid-soluble drugs. And, critically, any impairment to liver or kidney function means the patient just can't clear the drug as expected.
And if that variability is genetic, then personalized medicine or pharmacogenetics must be the key to unlocking true safety.
That is the promise of pharmacogenetics, using an individual genetic profile to predict their specific drug response, their efficacy, and their risk of adverse effects, moving from generalized dosing to maximizing the benefit-to-hazard ratio for that specific patient.
And those CYP enzymes, the key players in metabolism, are where we see some of the most dramatic genetic effects.
Absolutely. The status of CYP2D6 oxidation is a perfect example. This enzyme is highly polymorphic. If a patient is a poor metabolizer, they can't efficiently convert the prodrug codeine into active morphine.
So they get no pain relief.
Reduced or no pain relief. Conversely, an ultra-fast metabolizer converts codeine so quickly that they risk acute morphine toxicity.
The source says this affects about 10% of European populations. If the effect is so dramatic and so prevalent, why aren't we routinely screening every patient before prescribing codeine?
That's the crucial implementation gap. The barriers are largely logistical and economic. We'd need fast, cheap, point-of-care testing in every clinic. And we need education, so prescribers know which drugs rely on which enzymes and how to adjust the dose. Until that's seamless, we rely on educated guesswork and careful monitoring.
And beyond metabolism, genetic markers are used to screen for high-risk hypersensitivity reactions.
Yes, specifically the HLA polymorphisms. The presence of HLA-B5701 is strongly linked to a severe, sometimes fatal hypersensitivity reaction to the HIV drug abacavir. For drugs like that, genetic screening is now often mandated before you can prescribe it.
That shift from general dosing to personalized genetic testing really highlights the complexity of risk. Let's formally classify the types of drug harms, starting with adverse drug reactions, or ADRs.
ADRs are a massive public health issue. They account for about 7% of all emergency hospital admissions.
Wow.
But what's truly shocking is that the data show more than half of those ADRs are retrospectively deemed avoidable.
How can an ADR be avoidable?
It means the prescriber failed to anticipate a predictable hazard. For example, admissions from NSAI use causing gastrointestinal bleeding. In many cases, these patients were already high risk due to age or other drugs they were taking. Good prescribing means flagging those risks up front and choosing a safer alternative.
Let's classify the reactions.
We use the AD classification. Type A, for augmented, are predictable, common, and dose-dependent. They're extensions of the known pharmacology. Too much of a good thing.
Like constipation with opioids.
Exactly, or ankle edema with amlodipine. Because they're dose-dependent, you can usually manage them by just reducing the dose.
And type B, the unpredictable ones.
Type B, for bizarre, are not predictable, not dose-dependent in the therapeutic range, and rare. These are related to genetic or immunological hypersusceptibility. This is where you see anaphylaxis to penicillin or serious organ damage.
Given that rare type B ADRs often only emerge after a drug is widely used, how does the medical system even detect them?
This is the role of pharmacovigilance, the systematic monitoring of drug safety after licensing. A drug might be launched after being tested on just a few hundred people. Rare events won't be discovered until millions have taken it.
The UK uses the yellow card scheme for this.
Right, that voluntary reporting scheme was a direct response to the thalidomide disaster. It's an effective early warning system, but it has a profound limitation. The source states only about 3% of all ADRs are ever reported.
We are flying blind 97% of the time.
We are. We rely on clinicians making that intellectual leap. Once a suspicion is raised, we use frameworks like trend analysis to solidify the link. And clinically, the most important step is de-challenge. Does the reaction stop when you withdraw the drug?
ADRs can arise from a drug acting alone, but the risk explodes when we introduce drug interactions.
Interactions are almost inevitable with polypharmacy, and the risk is highest when the affected drug has a low TI. We divide them into pharmacodynamic and pharmacokinetic interactions.
Pharmacodynamic interactions affect the site of action.
They involve drugs affecting the same target or system, leading to augmented effects. Combining ACE inhibitors and NSAIDs significantly increases the risk of acute renal failure. Or, a simpler example, enhanced sedation when you combine benzodiazepines with alcohol.
Then we're back to pharmacokinetics, specifically metabolism, where one drug acts as a spanner in the works for another drug's clearance.
This is often the most dangerous type, and the timing difference between inhibition and induction is a critical insight.
So what happens when one drug inhibits the enzyme needed to clear a second drug?
CYP enzyme inhibition is a rapid acute risk. The inhibitor immediately ties up the enzyme, and the other drug's concentration rises quickly, sometimes within hours. A dangerous example is grapefruit juice. It inhibits CYP3A4, which can dramatically increase the concentration of drugs like amiodarone, risking severe cardiac arrhythmias.
And the opposite effect, speeding up metabolism.
CYP enzyme induction is a ticking time bomb. It's a delayed chronic failure risk. The inducer has to signal the liver to synthesize new enzyme molecules, which takes days, maybe 7 to 14 days, to reach peak effect. It slowly reduces the plasma concentration of the other drug.
Give us the classic example.
The herbal supplement St. John's wort. It's a potent CYP inducer. If a transplant patient starts taking it, their immunosuppressant concentration will gradually fall over the next 2 weeks. They lose their immunosuppression, risking acute transplant rejection.
Finally, we need to address the human element, medication errors.
They are preventable events leading to inappropriate use or harm. And they are pervasive. Studies consistently find that up to 9% of hospital prescriptions contain an error, often by junior doctors.
And we can categorize these using human error theory.
Exactly. The distinction is crucial for prevention. Slips or lapses are unintended errors, a failure of execution. The prescriber had the right knowledge but forgot a step, or wrote something illegibly.
And mistakes are based on wrong knowledge.
Mistakes are intended errors, but based on flawed judgment. For instance, prescribing a drug for the wrong diagnosis, or prescribing a contraindicated drug, like giving a beta blocker to a patient with severe asthma. Preventing mistakes requires better training and supervision.
Electronic prescribing systems seem like the ultimate tool here.
They are invaluable. They eliminate illegibility, which cuts down on slips. More importantly, they have clinical decision support systems that provide immediate warnings about allergies, interactions, and contraindications. They proactively prevent mistakes before they can reach the patient.
Okay, so now we turn from the science and risk to the art of clinical decision-making. What specific factors must a prescriber juggle before writing a prescription?
It has to be a methodical process. Diagnosis, setting a therapeutic goal, choosing the approach, selecting the drug and regimen, writing it down, informing the patient, and finally, monitoring and review.
Let's focus on that step, setting the goal. A prescriber has to first ask, is a drug even necessary?
Yeah, exactly. Concordance with the patient is paramount. They have to agree with the goal. And you have to consider non-drug alternatives. If a drug is chosen, the selection must be optimized for that patient's physiology.
So you have to tailor the drug to their existing organ function.
You must. Avoid highly metabolized drugs in severe liver disease, and any drug that depends on renal excretion like digoxin or gentamicin must be heavily dose-reduced in patients with kidney disease. Otherwise, accumulation is guaranteed.
And the safety profile can't worsen a coexisting disease.
That classic beta blocker and asthma contraindication. And you also have to balance things like cost and adherence. Prioritizing simpler, once-daily regimens is a clinical imperative because it dramatically improves patient adherence, which is often the single biggest reason for therapeutic failure.
Once the drug is chosen, we move to the dosage regimen.
The general rule for dose titration must be respected. Start low and titrate slowly upwards. This cautious approach is mandatory for the elderly, people with organ impairment, or when using those low TI drugs. You test the waters.
Route choice is often dictated by the drug itself.
It is. Dobutamine must be IV due to its short half-life. Salbutamol is inhaled to deliver the drug directly to the airways, maximizing local effect and minimizing systemic side effects.
And the timing matters.
Timing is crucial. Diuretics in the morning to avoid waking the patient up all night. Statins at night because the target enzyme's activity peaks when the patient is asleep. And with nitrates, we use eccentric dosing to deliberately create a drug-free period overnight to prevent tolerance.
Let's move to prescribing in specific high-risk circumstances, starting with patients with failing organs.
Renal disease requires extreme vigilance. Reduced clearance means accumulation. Specific drugs are high risk. Metformin can lead to life-threatening lactic acidosis. Spironolactone risks severe hyperkalemia.
What about the liver?
The liver has enormous reserve capacity, so big dosing changes are usually only needed when hepatic disease is advanced. But you have to be very cautious with opioids, which risk accumulation, and with warfarin, where liver damage can drastically increase the anticoagulation effect.
And prescribing for older patients is now routine, but it carries magnified risks.
The risks are multi-layered: reduced elimination, increased brain sensitivity, which can trigger delirium, and the inevitability of polypharmacy, which increases the risk of interactions and falls. The mandate is universal: lower starting doses and slower titration.
And finally, prescribing for pregnancy.
This is inherently high risk. The highest risk of teratogenesis fetal harm is during the first 10 weeks. Drugs like retinoids, ACE inhibitors, and warfarin are absolute contraindications during that window.
And does the mother's body handle drugs differently during pregnancy?
Yes, the maternal pharmacokinetics are significantly altered. The glomerular filtration rate increases by about 70%. This can enhance the renal clearance of many drugs, often leading to a fall in plasma concentration.
So you might actually need to increase the dose.
You might, though the guiding principle is always to only use drugs when the risk-benefit analysis overwhelmingly favors treating the mother.
Okay. Once all that is considered, the final stage is actually writing the prescription, which has to be error-proof.
A prescription is a legal document. It must be precise and legible, and the source highlights a critical error source. Unit writing. You must write micrograms and units in full. Never use abbreviations like U or MUG as they're frequently misread, leading to massive dosing errors.
And the generic versus brand name debate is also nuanced.
Generally, you use the generic name. But there are crucial exceptions for low TI drugs where minor differences in formulation can dramatically affect bioavailability. For drugs like lithium and phenytoin, the specific brand name, must be prescribed to avoid substitution errors that could lead to toxicity.
In the hospital, the drug chart is a crucial safety control.
It separates medications into once-only, regular, and the high-risk as-required sections. The as-required section is risky because it gives discretion to nurses, so the prescription must specify the indication, the minimum dose interval, and the maximum dose in 24 hours.
Okay, let's talk about drug management, monitoring, and the economics. Prescribing is a continuous life cycle.
It is. It involves continuous monitoring and regulatory oversight, always against a backdrop of significant economic constraints.
Let's start with how drugs are developed and regulated.
It's a marathon process. It costs billions and takes over a decade. It's organized into 4 clinical trial phases. Phase 1 is in healthy volunteers for basic safety. Phase 2 tests effectiveness in patients.
And phase 3 is the final large-scale confirmation.
Correct. Phase 3 involves hundreds or thousands of patients to confirm efficacy and safety. Phase 4 is the post-marketing surveillance we talked about, the continuous pharmacovigilance once the drug is widely available.
Once licensed, agencies assign restrictions based on abuse potential.
Right. We have controlled drugs like opioids, prescription-only medicines, pharmacy medicines, and general sales list, which are over-the-counter.
Now, a huge challenge is the rise of biologic therapies. How are these different from traditional small molecule drugs?
The difference is scale and complexity. Small molecule drugs like aspirin are chemically synthesized. Biologics, monoclonal antibodies are huge, complex molecules, often made using living cells.
And that massive size difference affects everything from manufacturing to cost.
Manufacturing is exponentially more complex, which drives up the cost. And when the patent expires, manufacturers introduce biosimilars. They have the same action but are similar, not chemically identical.
What unique risks do biologics carry?
Because they often suppress the immune system, the primary concern is a significantly increased risk of infection. For TNF inhibitors like infliximab, this includes reactivating latent infections like tuberculosis. So you have to screen for TB before starting treatment.
Okay, this brings us to the intersection of evidence, benefit, and cost. When evaluating trial data, we need to be aware of the risk reporting trap.
This is perhaps the most important non-clinical skill a prescriber needs. Clinical trials often highlight relative risk reduction, or RRR, because it sounds impressive. This drug reduces risk by 50%. But that means nothing without the absolute risk reduction, or ARR.
Can you walk us through the calculation?
Sure. Imagine a trial. In the placebo group, 2% of patients have a stroke. In the treatment group, 1% have a stroke. The RR is 50%. You cut the rate in half. But the ARR is only 2% minus 1%, which is 1%. You only prevented a stroke in 1 out of every 100 people treated.
And that leads directly to the number needed to treat, NNT.
The NNT is the reciprocal of the ARR. In that example, the NNT is 100. So 100 people must take this drug for 1 person to benefit, while the other 99 are only exposed to the costs and side effects. A good prescriber always translates the impressive relative risk into that necessary absolute risk.
Since healthcare budgets are limited, this leads to the hard financial math of cost-effectiveness analysis.
CEA compares costs and outcomes using the primary metric, the quality adjusted life year, or QALY. A QALY assigns a value of 1.0 to 1 year of perfect health.
And the calculation gives us the incremental cost-effectiveness ratio, or ICER.
The ICER is expressed as cost per QELY gained. It answers, how much extra does it cost us to buy 1 extra year of high-quality life? And health systems have an explicit or implicit threshold for this.
And if a treatment exceeds that threshold, it's rejected for funding, no matter how effective it is.
That's the hard reality of pharmacoeconomics. You cannot afford to pay, say, £40,000 for a benefit when you could invest that money elsewhere and achieve a greater population health gain. It mandates difficult choices.
Finally, monitoring the drug therapy itself.
Right. Ideally, we monitor the definitive clinical endpoints. But often the outcome is delayed, like preventing a heart attack. In these cases, we rely on surrogate endpoints.
Like using cholesterol levels as a surrogate for long-term MI risks.
Or monitoring C-reactive protein as a surrogate for resolving an infection. These biomarkers help us predict success or failure.
And if clinical effects are hard to monitor and the TI is low, we turn to therapeutic drug monitoring, or TDM.
TDM is only justified if 3 criteria are met. Clinical effects are hard to monitor, the plasma concentration predicts the effect, and the therapeutic index is low. Digoxin, phenytoin, lithium, and gentamicin all meet these criteria.
And when we draw a sample for TDM, timing is everything.
Critically so. Samples must be taken at the end of the dosage interval, the trough concentration, and you must only take that sample once steady state, 5 half-lives, has been reliably achieved. Otherwise, the measurement is useless.
And there's one final interpretation nuance.
Yes. For highly protein-bound drugs like phenytoin, we measure the total concentration. But only the unbound drug is active. If a patient has low plasma protein, their total drug level might look low, but their unbound active drug concentration could still be in the toxic range. A good prescriber always interprets TDM results within the full clinical context.
We've covered an incredible amount of ground today. We started with the molecular fit of a drug, traced its journey through the body, and ended in these complex, high-stakes decisions about risk, cost, and genetic variability.
The takeaway for you, the learner, is that the immense power of modern medication is only safely unlocked through constant scientific vigilance, continuous learning, and genuine shared decision-making concordance with the patient.
It's an overwhelming responsibility, and this deep dive really puts the spotlight on the rapid evolution of medicine, especially with the high cost and complexity of biologics. We talked about cost-effectiveness analysis using QLLYs and rejecting treatments that exceed that ICER threshold.
Right, the line in the sand, often around 30,000 pounds per QLLY saved.
Given that economic reality, here is a final provocative thought for you to consider. The source details the increasing effectiveness and complexity of these large molecule biologics. What are the long-term ethical implications for national health systems when deciding which new, highly effective but astronomically costly therapies should be made accessible to everyone, particularly when the benefit might only be an incremental improvement over existing cheaper treatments? Does the pursuit of therapeutic perfection justify potentially bankrupting the system for all other forms of care?
A profound question for any health economist or medical policymaker to grapple with in the coming decades.
That's all for this deep dive. We hope you feel thoroughly informed.